Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 548 of our pharmacotherapy series, which majors in bipolar disorder. The first case reads, DWY, a 34-year-old female singer and musician, recently experienced her fourth hospital admission for a manic episode. Her past medical history includes psoriasis and asthma. A trial of lithium led to worsening of her psoriasis and an unacceptable tremor, which interfered with her guitar playing. Use of propranolol was not considered because of her asthma. She was subsequently switched to valproic acid monotherapy. However, tremor has again become problematic. Furthermore, she is concerned about her appearance because she has begun to experience weight gain and hair loss from the valproic acid. What other drugs are available for the treatment of acute mania? Atypical antipsychotics can be selected as first-line choices for the treatment of acute mania. 3 recent systematic reviews and meta-analyses support the efficacy of atypical antipsychotics as a class. Perlis and colleagues reviewed data from 12 randomized, placebo-controlled, monotherapy studies and 6 adjunctive studies and found a collective response rate of 53% for atypical antipsychotics compared with 30% for placebo. There was no difference in response between the individual atypical antipsychotics. In adjunctive studies, the mean odds ratio was 2.4 for a 50% improvement with the addition of an atypical antipsychotic to a mood stabilizer, primarily lithium or valproic acid. Shirk and colleagues conducted a meta-analysis of 24 randomized controlled trials and found superiority of atypical antipsychotics for acute mania in comparison with placebo and equal efficacy to lithium, valproic acid, and haloperidol. In this analysis, the addition of an atypical antipsychotic to lithium, valproic acid, or carbamazepine was found to be more effective in reducing manic symptoms and yield less treatment discontinuation than lithium or the anticonvulsant alone. The results of a different meta-analysis specifically designed to evaluate combination treatment of atypical antipsychotics with lithium or an anticonvulsant also found greater efficacy for the combined regimen. In most combination therapy studies, atypical antipsychotics were limited to patients having no response or only a partial response to lithium or an anticonvulsant. Thus, the utility of drug combinations as initial therapy cannot be directly assessed. In a more recent systematic review of 68 randomized controlled trials, Eliminate, 2, comparing the efficacy and acceptability of anti-manic drugs either against placebo or against one another in the treatment of acute mania was completed via a multiple treatment meta-analysis. 14 treatment options were analyzed, including aripiprazole, acinapane, carbamazepine, valproic acid, gabapentin, haloperidol, lamotrigine, lithium, olanzapine, paliperidone, quetiapine, risperidone, topiramate, ziprasidone, and placebo. All of the antipsychotic drugs were found to be significantly more effective than mood stabilizers in the treatment of acute mania, with risperidone and olanzapine being ranked as superior for efficacy and tolerability. Lamotrigine, topiramate, and gabapentin were not significantly better than placebo in terms of efficacy and should not have a place in the treatment of acute mania. Additionally, a comparative analysis of 32 placebo-controlled trials demonstrated that YMRS scores improved significantly more with second-generation antipsychotics than mood stabilizers, but the efficacy needs to be balanced against anticipated common adverse effects. A significant concern about the use of atypical antipsychotics is the risk of metabolic complications, including weight gain, glucose dysregulation, and dyslipidemia. Clozapine and olanzapine have the highest risk for metabolic complications. Quetiapine, iloperidone, paliperidone, and risperidone are associated with an intermediate risk, and ziprasidone, brexpiprazole, cariprazine, acinapane, lurasidone, and aripiprazole appear to have the lowest risk. Clozapine is also associated with significant safety concerns, including agranulocytosis, seizures, sialorrhea, anticholinergic side effects, and orthostasis. Efficacy data with clozapine are limited compared with the other atypical antipsychotics, but clozapine appears to be effective in treatment-resistant mania and in long-term mood stabilization. Sedation is common with clozapine, olanzapine, acinapane, and quetiapine, and this effect may be beneficial in the treatment of acute mania. However, sedation can also lead to non-adherence with long-term use. Aripiprazole and ziprasidone are less sedating. Thus, the adjunctive use of a benzodiazepine is often necessary in the acute management of mania with these atypical antipsychotics. Adjunctive benzodiazepines may also benefit treatment of emergent akathisia, which occurs in 11% to 18% of patients treated with aripiprazole. Cariprazine has also been associated with treatment emergent akathisia and extrapyramidal disorders, that is greater than 10%. Acinapane can cause dysgeusia or oral hypoesthesia, although a black cherry formulation can help with the unpleasant taste. Ziprasidone may cause activation. However, this effect is attenuated at doses of 120 mg per day or more. Risperidone may overall be the best tolerated of the atypical antipsychotics, but this drug carries a higher risk for serum prolactin elevation and extrapyramidal symptoms. DWY's concern about her weight gain makes aripiprazole, cariprazine, acinapane, or ziprasidone rational choices for her manic episode. In addition to symptom response, DWY should be monitored for characteristic antipsychotic side effects, such as movement disorders and metabolic complications. If DWY fails to respond to the initially selected atypical antipsychotic, a switch to a different atypical antipsychotic may prove beneficial given the variability in individual response. The next question reads, what alternative agents are available for acute mania if lithium, valproic acid, or an atypical antipsychotic fail? Anticonvulsants. Carbamazepine represents an alternative treatment for the management of acute mania when lithium, valproic acid, and atypical antipsychotics fail. 11, 46, 47 in 2005, the FDA approved extended-release carbamazepine for the treatment of acute manic and mixed episodes based on the results of 2 double-blind, randomized, placebo-controlled trials. A meta-analysis of 4 randomized, controlled trials, N equal to 464 patients, found that maintenance treatment with carbamazepine has similar efficacy as, and fewer discontinuations due to adverse effects than, lithium. Despite demonstrated efficacy, carbamazepine remains a less than popular choice in bipolar disorder due to significant tolerability and drug-drug interaction risks. If elected for treatment, carbamazepine should be started at 100 to 200 mg twice daily. The dose should be increased by 200 mg every 3 to 4 days until adequate serum levels have been reached. Although no correlation between carbamazepine serum levels and response in bipolar disorder has been established, serum levels greater than 12 micrograms per milliliter are associated with sedation and ataxia. The recommended target serum level for seizure prophylaxis is 4 to 12 micrograms per milliliter. Average daily doses for maintenance therapy range from 200 to 1,600 mg per day. Oxcarbazepine, a structural analog of carbamazepine, offers some advantages over carbamazepine, including improved tolerability and fewer drug interactions. However, there is a paucity of well-designed clinical trials in bipolar disorder. Cochrane reviews suggest that there are insufficient trials of adequate methodological quality to recommend use for either acute or maintenance treatment for bipolar disorder. Other anticonvulsants studied in mania include lamotrigine, gabapentin, topiramate, tiagabane, zonosamide, and levetiracetam. Initial open-label studies of lamotrigine in mania were promising, but 2 unpublished trials were negative. Currently, experts doubt that lamotrigine has any significant effect in acute mania. Open trials and case reports suggested adjunctive treatment with gabapentin was effective in manic, hypomanic, and depressive states of bipolar disorder. A more recent controlled trial found no benefit of gabapentin. In this double-blind, placebo-controlled trial, gabapentin was administered as an adjunctive treatment in patients with bipolar I disorder whose current episode was manic, hypomanic, or mixed. At 12 weeks, gabapentin failed to show any significant benefit compared with placebo. In fact, the placebo group did significantly better than the gabapentin-treated patients. In 4 double-blind, placebo-controlled trials, topiramate did not separate from placebo and was less effective than lithium in the treatment of acute mania. Tiagabine, levetiracetam, and zonosamide have been studied in bipolar disorder, but lack adequate safety or efficacy data to receive any formal evaluation. We will now focus on combination treatment. Despite the array of treatments available for the management of acute mania, large numbers of patients fail to respond to monotherapy, and combination therapy is becoming a first-line treatment option. Potentially useful combinations include lithium plus atypical antipsychotics, valproic acid plus atypical antipsychotics, and lithium plus valproic acid. A combination to be avoided is carbamazepine and clozapine owing to the increased risk of hematologic adverse effects. Also, combinations of carbamazepine with either olanzapine or with risperidone result in more side effects and decreased efficacy. Therefore, these combinations are not recommended. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 549.